turn it over to Brian to talk a little bit more about prior authorization and the perspective from Edifecs. Brian, floor is yours.
Thank you. I like that you snagged my other life bio as a trombone player. Get my artistic side out there. Appreciate that. Let me share my screen. All right. Theoretically, you should be seeing my first slide.
Perfect.
All right.
We are.
Looks good.
All right. Perfect. So, really, obviously, in the theme of payer, provider, and patient impact, right? We want to look a little bit at trying to help all parties involved as much as we can, really figure out how to do this and how can you strategically implement. How do you gain value, right? I think Mark made a great comment that this is going to start as a compliance initiative because those are generally the technical folks who are the closest to those regulations and have the responsibility. But it will inevitably turn into a business transformation initiative at some point because of the far-reaching implications of the rule, both from a technical and business process standpoint, right? So, but the key thing in gaining value out of those is understanding where you have value to gain, right? So how do you build that consensus to actually implement? What are the actual benefits, right? So now, first off, of course, they say, presentation 101, start with a joke. So I'm going to start with a little funny cartoon here. I'll give everybody a chance to read this. The geeks among us have probably seen this, but the reason I bring it up is not to say that that's the situation we're in. It's more to say that this is the situation we do not want to be in. We don't want to just treat this as another regulation just because we recognized that there was a problem, right? I think everybody has recognized that PA has been a burr in the shoe, or thorn in the side, whatever colloquialism you'd like to say is out there. But now that we have a standard, right, we don't want to just be looking at it from terms of, oh, geez, how do I implement these 4 new requirements by XYZ date? That kind of misses the entire point of what burden reduction is meant to be. So if we look at prior auth from the IGs, right, and Bob did a great job of showing kind of how each step feeds the next, but offers kind of independent action depending upon your capability. And, we kind of understand, we see the ordering provider, we order the request, we collect all that data, it's all great. And technically that process is there. But if you have been out in the world working with providers like I have, working on the payer side too, you'll see that probably this picture is a little bit closer to what you might have experienced with PA. Reams of paper flowing back and forth, and that paper might be electronic replacement. It could be an electronic transaction, but what you get into with a lot of these real world situations is not everybody is at the same level of adoption. So, what if your EMR isn't fire compliant because even if there's an HTI rule, they decided not to be compliant for one reason or another? What if providers are still using legacy channels because they have bought 3 or 4 different locations and they all have different processes. So you've got 3 offices doing faxes and 1 office is using the electronic system. What if there's just no resources, right? You could have 4 offices all with just 1 person staffing all these processes, from front to back, depending upon your location and what resources you have available. So, how do you really, as a provider, if you put that hat on, get your head around dealing with this change and, at the same time, understanding that this change is going to require you to evaluate your PA process potentially for every single payer you deal with. So if you're a highly diversified, provider that's seeing lots of different members across lots of different, types of insurance, you've got a lot to deal with and understand, as far as even as much as we want to make the process the same, as several have alluded to, maybe Medicaid rules are different than your commercial rules. And we might get great adoption of the technology, but if the technology is adopted in such a way that all it really does is pushes the actual burden to another part of the process, we haven't really gained that much. So that's where, again, going back to that business transformation framework, you really have to think about this in terms of how can I make the whole thing better so that you don't inadvertently end up causing more of this, but maybe instead of paper flying around, it's 5 different versions of an implementation in your own EHR. That's what we don't want to have happen, right? So that doesn't necessarily mean the standard is wrong. It just means that you have to deal with how am I working with this unstructured data today? How do I get it structured? I think as several have talked about, but doing it in such a way that benefits the entire process end to end. So just kind of revisiting the process, right? We've got our provider, front office staff, they're working with the patient. Do we need prior auth? Again, echoing, I think, what Heidi was saying from a plan implementation perspective. This right here, if you did nothing else, adds tremendous benefit to the process if you can answer this question near real time. And having had direct experience with trying to answer this question from both perspectives, payer and vendor, it is a difficult thing to deal with. But presuming that you can figure that out, okay, now can I figure it out across all of my plans? And if I can't, okay, well, now I'm dealing with somebody maybe that can call somebody because I don't have time to deal with this patient right now. So now the patient continues to wait. They're talking with people at the health plan, whether it's benefits or, UM representatives. This is where the delay, the frustration, this kind of negative impact really starts coming to bear, because you've got now 2 people waiting on potentially a third person to have a conversation, and or one person waiting at a desk. It gets tiresome very quickly. So then we finally get the answer. Now they can move on to their next step in care, right? So in this case, you've likely got a sick member that needs care and doesn't even know whether they can get care, right? So that stress burden that's impacting their overall health. I think this is ultimately what we're trying to solve, right? And the point is to say, yes, there are lots of cases where providers are not using portals. Why? If they're not using portals today, the natural outflow of that is, why change to use something new that says supposedly is better than a portal, but the portals didn't bring me in a benefit, so why do this, right? Maybe the documentation needs, from my perspective, or as a provider, are excessive, or we've even heard from some, hey, this doesn't make sense, this is inaccurate, here's why. Many submissions are still being made via fax from, because that may be the most expeditious way to do it based upon the implementation. So anecdotally had one situation where, major hospital was, I believe they were faxing in all of their authorizations initials, but they were doing all their updates online. But it was because they had figured out that it actually saved them more time and effort to collect the records and move them back to a manual channel than it did to try and work their records that were in their electronic systems into the portal that was available to them. But on the flip side, it saved them a whole lot more time to use the features of that very same portal to update existing cases. So in that case, benefit to the provider and benefit to the member, but from the payer's perspective and the initial member experience, it's potentially slower than it could have been, but all ultimately because of what you could be argued is a valid reason on the provider side, as far as cost, control. So that again goes back to the burnout. You'll notice how all of these things, as you look at these problems, patients and limited visibility, they kind of all feed into one another, right? And you get these, tensions that pull at every person in the process. So the point I want to make is, there's still things you can do just because people are frustrated, right? Even if it's not something that, the rule, like take, for example, educating providers on automated PA value, right? Just because maybe your portal hasn't had the uptake that you would like to have, look at the rule, look at where it's going, stay engaged with your providers and say, hey, we as a payer are going to work on this because A, we're required to, but B, we think it's a good idea. So, keep them engaged, make them understand what the benefits are as the rule is coming to bear. As far as the provider side, right? You've got an opportunity to work with your EMR vendors to implement these transactions to say, can I figure out this coverage requirement burden? Talk to some providers that maintain, either playbooks that just have here's what website I go to check this payer's PA requirements. 100-page PowerPoint decks, binders of information that get handed down from one person to another. Right? There's an opportunity to really make those processes all be streamlined, but you may have to go out and seek those integrations. Right? It may not just come to you just because, especially with how these regulations tie together, right? If there are dates that don't necessarily align with when an EMR may be required to do something, it may be on you to go seek those things out if you really want to realize this value sooner. So another option that you can really do on the payer side is say, hey, I'm getting intakes via fax right now, but we've got all this new OCR technology, but we haven't actually implemented it in our authorization channel. And given the fact that this is going to be a multi-year implementation window, right? Maybe it makes sense to do some investments now on that intake towards the eventual back-end processing of these requests for is authorization required, right? So the more I can understand what types of services, even if it's just as simple as, hey, can I scan the cover sheet that I'm getting today and figure out what type of auth request I'm getting? That's something that will add value to understanding the implementation environment you're in. So really looking at your existing channels and saying, is there something that you can do now? Don't just kind of toss it out because you feel like, oh, everybody will go electronic. I think you've heard enough today to hear that there's significant challenges, even with this technology, towards adoption and rolling it out at scale. So if there are things you can do now, don't hesitate to try and make the case for them, because as long as you understand the context in which you're making that investment, it may yield and probably will yield benefits down the line. So another thing that you can do on the provider side is look at your existing processes, right? Like the example I gave, right? All these provider systems, if there's merging, large scale differences in what EMRs you've implemented, maybe this side of the business has Epic, this side of the business has Cerner, whatever it might be, you really need to start understanding those processes now and looking for those efficiencies, because this is the time to be really getting your strategy and your planning together so that you can have a successful implementation and kind of feeding back into start asking those questions about when are CRD APIs available, and can I start leveraging them so that I'm not caught flat-footed at the very end, and worst case scenario, you end up paying for functionality that you're not even using to its fullest extent because you haven't actually done the homework to know where you can implement them. And on the patient side, right, that limited visibility is something that payers can do and providers can do to a certain extent, depending upon who's offering the technology, is updating the API, right? Making sure that you've got to make that prior auth data available, but promoting the usage, right? Actually building features that leverage that data, right? So if there's another thing that you can do, maybe you're getting phone calls from your patients about, hey, I have a pending prior authorization. What's the status of it? You should be able to integrate that feature directly into your member mobile app if you're a payer and say, hey, it looks like that prior auth status is XYZ. Same thing for the provider side. With the capabilities of Provider Access API will unlock, you could do the same into your patient-facing application. So there's many different ways that you could source this data to the patients so that they're actually getting these benefits rather than just looking at it from it's just another cost of doing business type implementation. Again, back to that mentality of put the patient first, try to answer the questions that they have, and let it outflow from there. And then, lastly, on this slide here, just looking at the new reporting data and the opportunities that provides. So I think in the chat, we talked about this. I mentioned it when on the panel. The reporting requirement really, if you look at it, starts in 25 because you have to collect all of the data to report yearly metrics in 26. So if you're actually looking at ways to build use cases internally and start saying, hey, where is my spend actually at? How many authorizations am I getting? This is a non-trivial task, especially with the segmentation that's required within the rule. It may require you to make changes on how you're collecting data, how you're tracking authorizations internally, et cetera. So maybe that's the tip of the spear for you, right? So just the point of this is to all say, hey, there might be all kinds of excuses, maybe not to act yet, but there are mitigation strategies and or steps that I can take, even if the technology is not ready, to actually implement things and start the ball rolling, so that you don't end up caught behind the 8 ball, so to speak. So just looking from a payer's perspective, right? If we're talking payer, patient, and provider impacts, right? So in today's world, you have a situation, just back up a slide here. So where maybe, and this is probably even generous, 2% of the transactions are happening with a FHIR-enabled EMR. You've got 30% happening with legacy EMRs, maybe through 278s or something like that. Maybe 60% are coming out of the EMR, but are actually just turning into faxes. And then you've got providers that maybe you're even phoning them in because maybe they don't have readily an easy way to fax that volume of records. Whatever that mix is, the point is you've got all these channels today, and as a payer, you're going to have all these channels tomorrow. Right. It's just going to be a change in the percentage of these channels and how they're actually really staffed and implemented from a staffing and backend standpoint. And don't forget that one of the first rules that goes into effect on 1/1/26 is the turnaround time rule. So, when you're looking at this, you could look for strategies such as, okay, how do I take this backend data and maybe apply some AI NLP work to actually get the data in a structured format that is more friendly to usage within a FHIR context, right? So it's just one idea. I mean, there's many others that you could do, but it's just thinking through the things that you can do to enable you to be ready for the future, while you're still dealing with the reality that not everybody is going to be at the future at the same time. So as providers, right, the biggest thing I would kind of offer is embrace the change, right? You can be the change, live the change, go out, look for those pilot programs with your vendors and your payers, spend the time to understand the processes that are currently implemented. If it's been a while since you checked in with, the person that does prior auths at your satellite office, now's the time to start asking those questions and understanding what's happening. Give feedback to the payers, right? Especially on the medical policy front. I think there was a lot of discussion around, making automatable policies. Well, payers may not know that their policies are not as automatable as they can be because they don't necessarily know the nuance of how you're interpreting them from a provider's perspective. So if you're looking at something, it's an evidence-based guideline, and it doesn't make sense to you, make sure you've got a dialogue with the organizations at the payers where you're seeing these issues, because the sooner they can start getting this feedback, the higher the likelihood is that as this transformation effort starts to kind of reach scale within that organization, they kind of realize, oh, these are the things we're hearing and these are the problems that we're having, right? And this, again, ties back into that appeal metrics discussion, because they're going to require reporting on overturned appeals and things like that. There is an incentive for payers to really look at this and say, are we doing this and putting our best foot forward and really trying to save, everybody involved the burden that currently is brought with PA, but still have PA as a process, in its meaningful place in the overall ecosystem. And then, look at small scale changes, right? If you're looking at, the PA requirements, say those are being tracked on Post-it notes, in your process today. try to document who you're talking to, and keep track of those conversations. Start coming up with kind of an understanding of how you even know whether or not the answers that you're going to get using this new technology are the ones you expect, right? Because as with any new change, there's always a chance that something could go awry. So understanding what your own expectations are and keeping your business flowing the way you would expect as we move into this kind of maturation of the technology will be key in keeping that feedback loop going, so that when these implementations happen, just like I'm sure if those were involved in 4010 to 5010 or any of these implementations in the past, right? Payers are going to have some mechanism to deal with those types of issues. So you having an understanding of what you would expect is immensely helpful in helping the payers understand where the problems actually are. Then from a patient's perspective, I think I'd echo probably what Lorraine and CMS have been saying for years now. Own your data, right? If we're all patients in this ecosystem to a certain degree, I mean, even if you're on a commercial plan, make it known, hey, I want this, right? Look for those applications and look for those features that you could generally assume would be using these APIs. Ask about the health record transfers under the payer-to-payer rule. These are things that are meant to help ease the burden of patients at the end of the day. And if you take an active role, it's kind of like retirement planning or something like that. It may not be your favorite activity, and you might not want to think about all of these what if situations with the future, but it will pay off in the long run. And I think, taking that same mentality about being a good steward of your data, understanding who has it, where it lives, how it can be used to, your benefit, to help your provider give you better care, to help your payer more easily administer, your particular set of circumstances, right? If they know what authorizations you already have from a prior plan, that is an immense help to the new payer, right? So just all of those things, ultimately, the more people that are asking for them, the more chance there is they're going to be able to be implemented and be useful for you. Then lastly, this is just kind of a grid here. If we're looking at providers, patients, and payer impacts, right? We've got this. I won't read them to the group because you all can read, but just think about these types of situations and always be thinking about the three constituents that you're dealing with every single part of the rule. Because that will ultimately, I think, help you be able to have these conversations internally and, drive whatever your scope of this rule implementation may be, will help you drive this because you'll kind of understand the key points. And, our goal as Edifecs in general is to help all of our customers, work their way through this. Anybody that's interested in any aspect of this, always glad to help. But, we're just trying to get the word out there and let you know that, we are trying to think about this holistically, and definitely would advocate that anybody and everybody that has a stake in this implementing this rule would do the same.